Hello, I'm Dr. William Berger, Medical Director and founder of Northeast Medical Practice.
Good afternoon. I'm Irina Berger, co-founder of Northeast Medical Practice, and I work as an administrative director.
And we'd like to tell you a bit about our practice today.
So, Dr. Berger, tell me a little bit about Northeast Medical Practice. Tell a little bit about yourself, who you are, and why you were inspired to create the practice.
Of course. So, I'm an internal medicine physician, board certified in that specialty, also trained in obesity medicine, or what we can call weight management medicine, and also aesthetic medicine. And my journey is a little bit maybe unusual or non-traditional. I originally was a chemist, an environmental analytical food safety chemist for the state of Connecticut. I did a lot of research, published a lot of papers in scientific journals, and presented at conferences here in the States and in Europe. Did a lot of service work for environmental agencies as well as the Food and Drug Administration in DC. After 9/11, we did a lot of anti-bioterrorism kind of work. And I really enjoyed all of that. I felt like I was contributing to society. It was what I had wanted to do originally when I went to school. And during that time, I also taught introductory biology to nursing and PA students at Quinnipiac University. I did that a couple of nights a week for 10 years, the second half of that time that I was a chemist. And toward the end of that time, maybe a few years before I hit the 20-year mark, some people in my family became ill, and I helped them through that as best I could as a person with some background in biology and chemistry, but not a clinical person, just a family member. And then the proverbial light bulb went on that I really ought to be putting all of my interest in science, knowledge of biology and chemistry, and teaching into becoming a medical doctor. After all, doctore in Latin, it means teacher. So I was fortunate enough to be accepted into the charter class, the first class of the new medical school at Quinnipiac University. It's named for Frank Netter, the surgeon and famous anatomist who illustrated so many anatomical texts and advertisements and so forth. Pretty famous medical artist, as well as having been trained as a surgeon at NYU. And Netter was founded to create more primary care physicians because there's a shortage of them nationally. So I went through that program, decided to go into internal medicine, which is the specialty by which you can work outpatient as a primary care doctor, or you could work inpatient as a hospitalist these days, an internal medicine doctor in the hospital. I elected to go outpatient. It was always my desire to really interact with people in the community and develop relationships with my patients and have continuity of care, have patients ideally for many years whom I get to know well, maybe treat other members of their family and so forth. So I graduated from the Icahn School of Medicine at Mount Sinai program at Elmhurst Hospital. And in my third year of that training, my final year of residency is when COVID hit, and Elmhurst was right at the epicenter of that, as you folks probably know from the news back then. Really seen all kinds of medicine at Elmhurst, and the neighborhoods that Elmhurst sits in are the most diverse in the country. At least 125 languages are spoken in the two neighborhoods surrounding the hospital. And then on top of that came COVID. So I've seen a lot in my training. And then when I graduated, became a primary care physician, an internal medicine physician with Mount Sinai at a large multi-specialty practice, the biggest one in their ambulatory network on Long Island. I served there for 3 years and elected to open my own practice, which is Northeast Medical Practice.
So, what inspired you to go solo? I mean, you were well respected, you had phenomenal experience, and you were on their executive committee, and they perceived you as a high potential employee. What really inspired you to go and open up your own practice?
Yes, so across medicine in America, the widespread buyout of independent physician practices by hospital systems has really changed the way that medicine is practiced in this country. Between that and forces imposed by insurance, an awful lot has been done to tie the hands of the physician and force doctors to practice in ways that are not best for the patient, in my opinion, and definitely not best for all the doctors either. So what I'm referring to here is that doctors in the corporate setting are often, and this is across the board, not just in any one particular hospital-owned medical system, it's also this way in big group practices. Basically, you're forced to see patients very, very quickly and try to see as many as possible each day, so that a new patient physical at the most is about 20 minutes, 30 minutes booked, but you're supposed to have a little time to complete the note at the end of the visit before the next patient. And a follow-up visit is 15 minutes. And that's really going to be cut down to under 10 if the doctor wants to run on time and have all his charting done, or her charting done, before the end of the workday. However, I really feel that it's very important to spend enough time with the patient, not only so that they feel like they're heard and all of their concerns have been addressed during the visit, but because if you don't take the time with the patient, you don't find out things that are very, very important and things that would otherwise be missed. And I'll give you an example from just my first few months at Mount Sinai. So I would always give the patient as much time as I felt was needed to address the things that are of concern at that particular time. So I would often run late in clinic because of this, but I feel like you have to do things the right way, and better to run a little late and maybe make my patients wait a little bit, but practice good medicine. So I had a 40-year-old or so male patient come to me, new patient, because I was a new doctor, and I spend time on the intake side of the visit with a whole variety of things, past medical history and medicines and any allergies and things like this. What surgeries have you had? But you get to family history, and family history can be very, very important for determining what particular diseases you might need to look a little bit more closely at in the patient. So a lot of doctors kind of stop at maybe parents, maybe they'll ask about sibling family history, medical history. I always drill down at least to grandparents, all four. And on doing that, his parents really didn't have any major medical problems, maybe a little high blood pressure, cholesterol. But when I got to his father's father, his paternal grandfather, he died from a heart attack pretty early in life, around the same age as the patient that was sitting in front of me. And when I got his blood work back, and his cholesterol was kind of, on the cusp of being something I might want to think about treating. I said, between your family history and your grandfather, I know nothing's happened with your dad, thank God. But with your grandfather, I really think we should do a little bit deeper digging. We should get a coronary artery calcium score, which is a snapshot CAT scan of the heart to look for calcifications in the coronaries that would be essentially caps on old cholesterol plaque in those vessels. And it's those plaques that can rupture and cause a heart attack, or just become so big that they block the flow and you get chest pain when you exert yourself, and can also lead to a heart attack if you overdo it. So I got a coronary artery calcium score. It was quite elevated. I had him go to see cardiology because I wanted them to evaluate him, get a stress test and so forth. Did a stress test. It showed some ischemia, that part of his heart was not getting enough blood flow. And they went and did a coronary angiogram, where they go in with a catheter, inject dye under imaging, and basically you're looking at how the blood flow, by watching the contrast, by watching the agent flow through the coronary arteries. They could see that he had a 95% occlusion of the left anterior descending artery, the LAD. This is the one that's colloquially called the widowmaker if you have a blockage there and a heart attack, because it's often fatal. And so he had a stent placed. They opened up the LAD, and when he came back in to see me, he was just very, very grateful. He said, you know, Doc, you saved my life. I'm gonna, God willing, see my kids graduate from high school now, and, you know, college hopefully, and, you know, see them get married, grandkids, etc., because you took the time with me. So I find it very, very important, and this is why, kind of a long story to get to the answer to your question, of why I've started my own practice. So here in our practice, a new patient visit or an annual physical for an existing patient is going to be 60 minutes. That's the time that's blocked out in the schedule. 30 minutes for a follow-up visit. Something acute might be 15 minutes, you know, just a cold or something like that. But for an annual or a new patient, an hour. For a follow-up, 30 minutes. Because I think that's the only way you can practice good medicine.
Incredible story, and beautiful the reason why to go into, you know, to your own practice. You're also offering weight management, right? I mean, primary care, weight management, and injectables. Would you be kind enough to speak a little bit about weight management and what inspired you to actually concentrate on those type of services?
Of course. So in my training and in my practice as a primary care doctor before we opened Northeast Medical Practice, modern medicine, Western medicine is typically reactive. We have a pill for every ill, is often the way that it's put. We spend not too much time on prevention and lots of time on treatment once chronic diseases arise, hypertension, diabetes, high cholesterol, and then, God forbid, managing all that stuff in patients that have had heart attacks and strokes and things of this sort that are often the byproduct of those conditions. And they're really all kind of together in something called metabolic syndrome. And so this has to do with blood pressure, with triglycerides, a type of lipids, a type of the things that you look at on a lipid panel in addition to cholesterol, the HDL cholesterol, among other things. But you know, this syndrome typically involves insulin resistance, potentially leading to diabetes, high blood pressure, obesity, and basically, to my thinking and the thinking of the Obesity Medicine Association, with whom I'm trained to become more expert in the treatment of obesity, basically having a high adiposity is the mother of most of the chronic diseases in this country that make cardiovascular disease the #1 killer of people in this country. And so that means you have to look at not only the patient's lifestyle, but also behavior and the potential role for some medicine to help control weight. So there are between 4 and 6 pillars, depending on whether you're from the Lifestyle Medicine College or the Obesity Medicine Association, but they really overlap quite a bit, and I belong to the American College of Lifestyle Medicine too. So the American College of Lifestyle Medicine doesn't focus as much on medicine, they focus as in medication, they focus more on the lifestyle side of things. So they're concerned with nutrition, often a whole food, plant-based diet, physical activity and exercise, proper sleep, restful sleep, reducing stress, avoiding risky substances, and basically having good social interactions with friends and family. And all of these are exceedingly important for maintaining good health. In the Obesity Medicine Association, the 4 pillars that they discuss are also, of course, nutrition, diet, not necessarily whole food plant-based, but certainly whole food and avoiding processed foods, minimizing them. And of course, exercise and physical activity. Behavior modification, and this is where health coaching can be very helpful, because doctor can advise all sorts of things, but if the patient doesn't have the tools to change their bad habits, not much is going to be done. But the fourth pillar for obesity medicine trained physicians are the medications, and of course, very much in the news these days are some of the injectable GLP-1 receptor agonist medications, which maybe we can talk about later in this particular chat. But that is the reason that I wanted to go and learn more about treating weight and obesity, because it is really the thing that sets up that whole horrible chronic inflammatory insulin resistant syndrome that leads to diabetes, hypertension, and stroke and heart attack and peripheral artery disease of the legs and so forth. So if you don't work on that preventive side, then you end up treating people who have already developed all of these things, and it becomes much harder to reverse them. You can treat them, you can try to control them, but it's much better if they don't actually ever happen. But getting people's weight down, often all those other things start to simmer down as well.
Yeah, so a lot of people just looking for magic pill, right? I mean, and you refer to pharmacology in terms of Ozempic, Wegovy, and Mounjaro, right? And you're also saying that there are some drugs in development. So tell a little bit about assessment. I mean, you have scale, right? And you know, the fact that you're also doing this holistically and not only emphasizing on the pill but overall, right? I mean, meal replacement. Tell a little bit about the assessment and what you have been doing for your patients overall.
Right, so as you're alluding to, I don't simply write a prescription for one of these new medicines, hope that insurance covers it and the patient gets on it and loses weight, and see you 6 months, basically. As I mentioned with all the pillars, either of lifestyle medicine or obesity medicine, you need to come at it from both sides, from the lifestyle side, which is going to include changing diet, exercise, proper sleep. Sleep deprivation really can drive weight. It makes it harder to lose weight. When you're sleep deprived, you crave less healthy foods, you tend to eat more. So sleep, very important. It's not just, I'll sleep when I have the time to sleep, or I'll catch up on the weekend. It's very important to get at least 7 hours. Helping people to change behavior, which is where the health coaching can come in.
Do you offer internal coaching in the house?
We do. So again, I think that's really important to that will help give the patient the best chance of actually changing their habits. And then we can think about medicine too. It's not that I do all of those things, see how we go, and then start medicine necessarily. If the patient is, if their weight is high enough, we're going to start medicine in parallel to doing all of those lifestyle things. But the way I like to set up a patient's treatment plan with their weight is basically I'm going to see them every 2 to 4 weeks, depending on the situation, and each time we're going to delve a little bit deeper into all of the things that are the challenges of the patient, and if we address them, can help them get the weight down. So in terms of assessing on the objective side, the physical examination side, as you alluded to, we have a bioimpedance scale here. So not only does it calculate your height and your weight, it actually gets your height with an ultrasonic sensor above the patient. So it gives you the BMI immediately, but it can also determine your percent fat mass and your percent lean body mass, because it's very important while a patient loses weight to try to maximize the loss of adipose tissue but minimize the loss of muscle. So a lot of times when patients are started on these new medicines, if they're not really being monitored and coached and treated in a, as you said, holistic fashion, they may not be paying attention to how much muscle they're losing. Some of these new medicines, they can decrease appetite to the point where the patient is almost becoming a little bit malnourished. They're not getting enough protein in particular. And if you don't maximize protein, lean, healthy protein intake, and also incorporate resistance training, strength training, patients who don't have a lot of muscle mass to begin with, for example, they can even become what we call sarcopenic, really, really low amount of muscle. So without a scale like ours, or in research settings, a DEXA, a bone density scan, without some way beyond just a regular scale and taking the patient's height, if you don't pay attention to the lean body mass and the fat mass proportion over time, you may not realize that the patient needs more protein, needs to do more weight-bearing exercise, these kinds of things. So you can push on those levers if you have the data that tells you that you need to push harder on those levers. If you don't have the information, then you may just kind of in passing say, make sure you're doing some weight-bearing exercise, make sure you eat more protein. But if you actually have data showing that percent body lean body mass is going down much more than we would like, then you really have a reason to have that conversation with the patient and advise them on protein and weight-bearing exercise.
So speak a little bit about meal replacement, because
Right.
you mentioned about the fiber,
Mm-hmm.
and sometimes it can, the diet can go to not enough nutrition,
Mm-hmm.
right? I mean, I know you're working with New Direction, and can you talk a little bit about?
Sure. Sure. So meal replacement has been used in obesity medicine for many years. Basically what it is there are products like bars, shakes, soups, and so forth. We get them from Robard, a very reputable company that's been around for many, many years, decades. And they've published many clinical papers as well, showing that their products can help patients reverse diabetes, and so in addition to losing weight, of course. So they're very well formulated. They have all the proper amount of different types of fiber to not only help you feel full longer, but to be feeding the microbiome of the gut properly. And also reducing spikes in your blood sugar that happen when you eat highly processed, refined carbohydrates, things with white flour and high fructose corn syrup and so forth. And they make it very easy to decrease the energy intake. In other words, reduce the number of calories that a patient eats every day. Because if you have one shake in the morning and then you have a bar in the middle of the morning, and maybe a soup for lunch, a bar in the afternoon, and then let's say a healthy home-cooked meal for dinner, you're automatically controlling all the calories up until dinner time, and then hopefully you're eating a healthy meal and not too large a portion for dinner, and then you're reducing your calorie intake from where you were prior to starting the program, and that of course is by the the laws of thermodynamics, less energy in, you're going to lose weight. And it makes it super easy. You don't have to buy particular ingredients from the store and learn recipes to cook and so forth. You should do that, and it's great to do that. And if you're not on meal replacement 6 times a day and replacing all of your meals and snacks with these products, if you're still making a meal, then of course you do need to know how to prepare a healthy meal and buy things at the grocery store. But it really simplifies breakfast and snacks and so forth. And if you're tempted to go stop and buy an unhealthy snack in the mid-afternoon, you have a bar with you, have a bar, and then you're satisfied until dinner time. So it can really help people stay on track. It simplifies the diet. They're delicious, I can say from my own experience with the products, and having tried them, and lots and lots of data showing that they can help the patient lose weight. Of course, the more you calorie restrict, the faster you're going to lose weight. But this is something that we work out in a patient-centered way with what the goals of the patient are, what the patient's comfortable doing. Maybe we'll start just with replacing breakfast and the snack before lunch, and let them, then the patient elects to eat up regular foods for the rest of the day, whatever we agree to, in a collaborative manner.
And patient can purchase all this.
Correct. We have all those products here, and so I can develop a nutrition plan using those products with the patient. Of course, we can also develop a nutrition plan without them, using particular other types of diets. I'm a proponent of the Mediterranean diet for a variety of reasons. I think the best data in the best medical journals are in support of the Mediterranean diet, as well as the DASH diet, which is one developed primarily to try to control blood pressure, but can also help with weight loss if used in a particular way. I'm not against keto and other diets, but they're a little bit harder for patients to stay on, and that's a broader conversation about diets. In general, the one that a patient enjoys and will actually adhere to, stay on, that's the diet for the patient. But that's a conversation for another day. But we offer the meal replacement program here. It's an excellent product and reasonably priced, and makes it much easier for the patient because everything is very defined.
And you also have a third part of services that you're offering, injectables.
Mm-hmm.
Can you talk a little bit about what kind of injectables you're doing, and also the reason behind?
Mm-hmm. Of course. So aesthetic medicine, I feel, is important for patients too. Many patients not only want to feel better on the inside, but also feel better about their appearance. And I'm a car guy, so I think of it like if you have a classic Porsche or Ferrari and it gets a few dings and paint chips and whatnot over time, you'd consider taking it to the body shop and giving it a nice fresh paint job, right? No reason to drive it around with these imperfections in its appearance, even though you may have been taking top-notch care of it mechanically underneath the skin, if you will. So what we offer are neurotoxin, so that's Botox, Dysport, Xeomin, which can control lines of the forehead, between the eyes, the crow's feet, and so forth. It has other applications too, like excessive sweating, called hyperhidrosis of the armpits, or the palms of the hands. Can be used to treat migraines and so forth. It works basically by not allowing the nerves to talk to the muscle and make it contract, without getting into too much detail about how it works. But also we lose volume in the face as we age. There are fat pads in all different parts of the face, and they recede and sometimes drop with time. And also you have resorption of bone, just like you kind of, you can tend to lose bone in the spine or in the hips and femurs and so forth as you age. There's bone recession naturally in parts of the face that can cause lines to form in various places. So by basically replacing that lost volume that happened because of fat pad loss or movement and bone resorption with dermal fillers, most often hyaluronic acid fillers. We use Restylane products from Galderma mostly, but products from Juvederm and others they're all excellent. So we can replace the lost volume, and that often will soften and remove some of those lines and or jowling or other things that patients don't find as attractive for themselves, that they would like to try to correct. So,
and how do you make sure that you keep your patients the most natural looking?
Right. So I always take a very conservative approach to treating patients with aesthetic medicine. My goal is for nobody to necessarily know that the patient actually had anything done. So people may say, "Oh, you look more rested. You look good. You come back from vacation." So I do that by taking a very conservative approach to the treatment. So I I never want to overdo it, because we all know the person who walks in the room and you instantaneously can see that they've had a lot of filler, or they had Botox that wasn't done correctly, because their eyebrows are peaked on the sides and things like this. But the filler in particular, when it's overdone, it gives unnatural shapes to the face. You should have some nasolabial fold, for example. If you have none because you've been overfilled, it looks unnatural, and you immediately pick it up when you look at that person's face. So I don't want any of my patients to have that appearance, to get that reaction when they meet people. And this is my work. It's kind of, the artist who puts the painting on the wall, they want something that truly reflects their skill and ability, and I don't want my patients going out into the world overdone. So I will even turn down patient requests sometimes for more filler to the lips or more filler in the cheeks and things like this, because I know it's not going to give a good result. The patient may want it reversed later, and it's not going to give a natural, refreshed look. It's going to give something unnatural, and that's what I want to avoid.
Thank you. That was a phenomenal overview of your background, practice, services. So what's next? I mean, how are you going to advertise and really put your brand out there? What are you planning to do in terms of advertisement? What the followers can expect from you?
Mm-hmm. So we have a wonderful new website, first and foremost, which is a great place to learn more about the practice, and it's also a way for me to further educate our patients and potential patients excuse me, about everything that we offer, and also general topics in medicine, things that are going on with COVID, or with other pertinent current events in medicine, if you will, things that are of concern in medicine for our patients. So to that end, videos like this we're putting in full on the website. Portions of them we're going to put on our social media outlets, so Facebook, Instagram, and LinkedIn primarily. I'm also going to be blogging on medical topics on the website, so videos and blogs would be what you find on our site, which is northeastmedicalpractice.com. And excerpts and so forth will be found on the social media, and also be out and about locally here. We're in Great Neck on the North Shore of Long Island in Nassau County, so right next to the borough of Queens of New York City. And so we're going to be out and about giving presentations. I'll be giving a talk at our lovely public library during Obesity Medicine Week in March of 2024. Coming up sooner will be a talk at our synagogue, the Lake Success Jewish Center, a date to be determined there. Also, for those in the medical field, there's a medical association here in Great Neck called the Sephardic American Medical Association, where I'll be giving a talk on obesity medicine and management of weight probably in November. So patients can stay tuned to our website and our social media outlets for announcements about all of that. And even sooner, and perhaps even more joyous than that, when we schedule our grand opening for the practice here. We are currently seeing new patients, and of course accepting new patients as we're a new practice. But we're going to want to have our growing family of Northeast Medical Practice patients and new and potential patients, people interested in the practice, to come and join us for our grand opening, which will be shortly, and we'll be putting the date and time up on the website.
I forgot to ask you, you accept all sorts of insurance, medical insurance?
Yes, just to circle back, of course, patients always ask this. It's one of the first questions when they hear that I have a new medical practice. Absolutely, I think it's important for patients to be able to get access, and one of the ways that most patients want to obtain access to their doctor is through their medical insurance. So we accept Medicare, Medicaid, and most of the major private payers in our area.
And for injectables, care credit is also
Right. So medical insurance does not cover the aesthetic medicine, except in some small instances where it's not really aesthetic, it's more medical. But yes, so that's cash based, but we do offer care credit, which is essentially allows the patient to purchase their aesthetic medicine treatment with the use of this credit program that allows them to pay it back in monthly installments and so forth, and they can obtain further details about that when they visit the office.
Thank you, Dr. Berger. It was very informative.
Thank you, Irina. It was a pleasure.
Thank you.